बाद कट कर दीजिएगा। हाँ, थोड़ी देर बाद। साउंड का
लो show the free also.
A very good afternoon and warm welcome to everyone. मैं डॉक्टर अरुण सचदेवा डिपार्टमेंट ऑफ मेडिसिन आज VPIMS द्वारा आयोजित 38th एनुअल CME के उद्घाटन में आप सबका स्वागत करता हूं। Vivekanand Polyclinic and Institute of Medical Sciences is one of the leading frontiers in the healthcare in Uttar Pradesh, covering all the specialities and super specialities in medical and surgical care. This institute had started its journey as a small clinic in 1925 at Aminabad area and has now transformed into a 350-bedded multi-speciality tertiary care teaching hospital since 1970 with the blessings of Swami Vivekananda. Year by year, this CME organized by our institute is not just an event but a clear testimony of the collection of commitment by all of us to achieve medical excellence. I am sure this CME will prove again to be a converging point for the trailblazing ideas and transformative insights. As Swami Vivekananda had said, pleasure is not the goal of man but knowledge. Pleasure and happiness come to an end. It is a mistake to suppose that pleasure is the goal. The goal of mankind is knowledge. Vivekanand Polyclinic and Institute of Medical Sciences and Ramakrishna Seva Ashram has always believed in one thing: health is a human right for all the people and not a privilege for those who can afford it. Working in the same direction and vision for universal health care for all, this CME focuses on promoting health, preventing disease as well as treating them. With this, I would like to call upon the dignitaries for the evening. May I invite our chief guest, Dr. G.N.Singh sir, Swami Muktinathanandaji, our secretary, Dr. Bhabatosh Vishwas sir, Dr. R.K. Sharma sir, and Dr. Debashish Saha sir, to please come forward for the floral offering to the Divinity Trinity Swami Ramakrishna Paramhans ji, Ma Sharda Devi ji, and Swami Vivekanand ji, followed by lighting of the lamp amidst Vedic chanting.
श्रीगुरुभ्यो नमः हरि ओम्। सहनाववतु सहनो भुनक्तु सह वीर्यं करवावहे तेजस्विनावधीतमस्तु मा विद्विषावहे। ॐ शान्ति शान्ति शान्तिः। ॐ सन्नो मित्रः संवरुण सन्नो भवतु यमा सन्नो इन्द्रो बृहस्पतिः सन्नो विष्णुरुक्रमा। नमो ब्रह्मणे नमस्ते वायो त्वमेव प्रत्यक्षं ब्रह्मासि त्वमेव प्रत्यक्षं ब्रह्म वदिष्यामि हृदं वदिष्यामि सत्यं वदिष्यामि तन्मार्मवतु तद्वक्तार्मवतु आवतु माम् आवतु वक्तारम्। ॐ शान्ति शान्ति शान्तिः। नमो श्रीरतिराजाय विवेकानन्दसूर सच्चित्सुखस्वरूपाय स्वामिने तापहारिणे। ॐ पूर्णमदः पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते। ॐ शान्ति शान्ति शान्तिः। हरि ओम तत्सत्। श्रीराम कृष्णाय प्रणमस्तु।
Thank you so much. Now I will request the dignitaries, Swamiji, Dr. G.N.Singh sir and Bhavutosh Vishwas sir to please take the dais. Happiness. To be happy, genuinely happy, we all require a proper balance between spirituality and science. But in our society, we don't see this. This ideal equilibrium is disturbed when science and logistic reasoning gets the main share, but there's an internal vacuum, which results in a continuous search in the external world for the fulfillment of one's desires. Swami Muktinathanandaji is a perfect example of the balance between two, who has proven that both are not antagonistic and a sound equilibrium is possible. We all know him for his vision, commitment, hard work, administrative skills, and gracious nature. He is a leader who had modern university education and traditional spiritual training. He himself always believed and said, science without spirituality is lame, and spirituality without science is blind. Swamiji has vision and belief and ability to convert visions into reality. Transformation of a small clinic to this multi-speciality institute and now making it one of the best health care givers in the state with NABH accreditation from 2018 and never stopping regular upgradations of the hospital are just to name a few. Now I would like to call upon the Secretary of the Vivekanand Polyclinic and Institute of Medical Sciences, Swami Muktinathanandaji, to deliver the welcome address. Swamiji.
Jananim Sarvadam Devim Ramakrishnam Jagadgurum Padapadme Tayo Shtitva Pranamami Muhun Muhum Namah Shri Jathirajaya Vivekananda Suray Satchit Sukha Swarupaya Swamine Tapaharine. It's a proud moment for us because we have amongst us Professor Dr. Bhavatas Biswas, was the former Vice Chancellor of West Bengal Medical University, Vice President of NBE, New Delhi, Head and Architect of the Cardiovascular Thoracic Surgery in RG Medical College, Kolkata, the Principal of Ramakrishna Mission Seva Pratishthan, elevating it the height of a medical college. And now he has, by the will of Swamiji, he has dedicated his time to elevate our hospital to a great height. He is the architect to bring amongst us Dr. G.N.Singh, who is the Central Drug Inspector General of India for a long time, and now is the medical advisor to our Chief Minister, Adityanath Yogi ji. As soon as he arrived, he called me, Swamiji, make it a medical university. Just by looking at our hospital, that was his inference. He didn't stop here. He was placed to visit Belun Mott and meet the General Secretary with a request from the Chief Minister to convert this institute into a huge university. There is a blessing of Swamiji on him. We are thankful to our learned speakers today, Professor R.K. Sharma, Nakul Sinha, Dr. Bhavatas Biswas, and Rohit Kapoor, who is the son of Rakesh Kapoor, the head of Medanta. And also our learned chairpersons will have a feast of knowledge right now. Sri Ramakrishna said in Bengali, Javad Bachi Tavad Sikhi. As long as do I live, so long do I learn. The reverse is also true, especially in medical profession. As long as I learn, so long do I live. If you stop the curve of learning, you are gone, you are rejected, like a dead leaf of a tree. Swami Vivekananda, while framing the Ramakrishna mission, used the warning, Vidya charchara bhave sangohin dasha prapta hoy. Any organization degrades due to lack of the study and teaching, lack of learning. So this institute is pledged to go on elevating its standard, but that is never possible without our medical education. So the premier asset of our hospital is our DNB students. Every one of us must take care of them because they are the principal agents who will take our hospital to the great height. And today's CME is, the annual CME is a line of encouragement to an entire professions. They have to learn and they have to keep up the curve of learning and they have to elevate this hospital and themselves by sheerly encouraging the process of teaching and training and learning. So from the bottom of my heart, I congratulate, thank and express my gratitude to Dr. G.N.Singh for readily accepting in a day's notice to become the chief guest. Now also he has to rush. The call from the Chief Minister, he has to rush. Even then, he squeezed his time and has graced us by his presence. I On behalf of you all and behalf of the institution, I seek the blessings of Swami Vivekananda on him and seek his guidance in the days to come. I thank Dr. Bhagavatas Biswas for being a source of inspiration to us all. I thank and welcome our learned speakers, our own doctors, consultants, our dear DNB students for a grand feast now, followed by our inaugural session by Sri Asim Arun, the minister, and followed by a grand high tea. All of you are heartily welcome. Thank you.
Thank you, Swamiji. Now may I request Swami Muktinathanandaji to felicitate and welcome Dr. G.N.Singh, Sir, Advisor to the Honorable Chief Minister, UP Government, and former DCGI Head, Government of India. Dr. G.N.Singh, Sir. Now may I request Swamiji to felicitate Dr. Bhagavatas Biswas, Sir. Now may I request Dr. Devashish Saha, Sir, to felicitate Swamiji. I would request the dignitaries to felicitate Dr. R.K. Sharma, Sir, Director and HOD, Nephrology and Kidney Transplant Medicine, Medanta Super Specialty Hospital, and former Dean and Director, SGPGIMS, Lucknow. Dr. Nakul Sinha, Sir. I stand proud here and honored to introduce Dr. G.N.Singh, our chief guest for the evening. Sir is the advisor to the Honorable Chief Minister, Government of Uttar Pradesh, and he is the founder, director of Indian Pharmacopoeias Commission, Ministry of Health and Family Welfare. He has served as Drug Controller General India, and he is known for establishing the Medi Wellness City in Lucknow and the telemedicine initiatives of the UP government. Sir, if you please will.
आज हमारे जीवन का सबसे महत्वपूर्ण दिन है कि इस महान संस्थान में आने का सौभाग्य प्राप्त हुआ है और इसका श्रेय हमारे जो गुरु हैं भावतोष विश्वास जी को जाता है। आज स्वामी मुक्तानंद जी के चरणों में स्थान मिला, इसके लिए हम अपने आप को बहुत गर्वान्वित महसूस करते हैं। देखिए, दो विभूतियाँ जिन्होंने इस महान संस्थान को बनाने में पूरे देश को, विश्व में अपनी एक नई दिशा दी है, उनके चरणों में हम नमस्कार करते हैं। दोनों हमारे दाएं बाएं हैं और ये आप सारे लोगों को आशीर्वाद दे रहे हैं। जब हम चले थे तो माननीय मुख्यमंत्री जी ने आप सारे लोगों को अपनी शुभकामनाएं दी हैं और उनकी ये इच्छा है। जब हम देखिए, ये दूसरा हमारा CME है। केवल जीवन में एक बार हम गोरखनाथ अस्पताल जो गोरखपुर में है वहाँ गए थे। माननीय मुख्यमंत्री जी उस समय मेंबर ऑफ पार्लियामेंट थे और इसी तरह हमें सारे आप जैसे महान विद्वानों के सामने खड़े होने का सौभाग्य प्राप्त हुआ था। तब हमने आग्रह किया था माननीय योगी जी से कि एक विश्वविद्यालय बनाने की परिकल्पना की जाए और स्वामी जी आपके लोगों के आशीर्वाद से आज महायोगी गोरखनाथ विश्वविद्यालय गोरखपुर में फलता फूलता नज़र आने लगा। अभी बच्चा है, लेकिन आने वाले समय में आई एम कॉन्फिडेंट इट वुड सेट many new standards in medical sciences and healthcare education both। आज जब हम इस कैंपस में जैसे ही एंट्री पाए, हमारे मन में एक इच्छा हुई, क्योंकि ये दूसरी CME है, तो हमने ये सोचा कि क्या नई चीज़ होने वाली है। ये हमारे मन में नहीं, ये भगवान की कृपा है। इन दो महापुरुषों का सीधा सामंजस्य प्राप्त हो रहा है। आज हम लोग ये प्रतिज्ञा करें कि इस संस्थान को हम लोग स्वामी विवेकानंद विश्वविद्यालय लखनऊ बना के रहेंगे। आप सारे लोगों से हमारा आग्रह है कि स्वामी जी के हाथों को आप मजबूत करें। जब माननीय मुख्यमंत्री जी हर ज़िले में एक एक हमारे मेडिकल कॉलेज, स्वामी जी आपको खुशी होगी कि हम लोग सबसे ज़्यादा मेडिकल कॉलेज बनाने का एक अपना इतिहास बना चुके हैं और अगर ये एक ऐड होगा तो ये हमारे पूरे उत्तर प्रदेश के लिए एक नई दिशा देगा। और यही जो स्टैंडर्ड्स, चाहे हम NMC को करें, चाहे किसी एक्रेडिटेशन बॉडी की बात करें, उसमें सबसे बड़ा ये है कि आदर्श कौन होगा। हमें पूरा भरोसा है जो स्वामी जी के नेतृत्व में ये संस्थान, ये हॉस्पिटल, नर्सिंग कोर्सेस, सारी चीज़ें चल रही हैं, ये संभव है। और स्वामी जी आपसे करबद्ध हमारी प्रार्थना है कि आप इसको विश्वविद्यालय बनाएं और हम भावतोष विश्वास जी से आग्रह करेंगे कि जहाँ भी चलना हो हम लोग चलेंगे। देखिए, हम काशी हिंदू विश्वविद्यालय से पढ़े हुए हैं। उस समय मालवीय जी ने कभी ये सोचा नहीं था कि जेब खाली है और इतना बड़ा विश्वविद्यालय खड़ा कर देंगे, लेकिन जब आपका संकल्प बड़ा होता है तो भगवान सहायता करते हैं और आज इतना बड़ा विश्वविद्यालय तैयार है। हमें पूरा भरोसा है कि स्वामी जी ने जब संकल्प आज पहले से किए हुए हैं, आज हम लोग उस संकल्प को पुनः आपसे आग्रह कर रहे हैं। ये जितने लोग बैठे हैं, देखिए माननीय मुख्यमंत्री जी जब उत्तर प्रदेश में आए तो उन्हें लगा कि नहीं, स्वास्थ्य और शिक्षा में अभूतपूर्व परिवर्तन करने का समय आ गया है। उसके लिए उन्होंने बड़ी ही तन्मन्यता से, देखिए लॉ एंड ऑर्डर की जो सिचुएशन थी वो बहुत ही विकट थी। आज उत्तर प्रदेश पूरे हिंदुस्तान में, विश्व में एक अपने आप में आदर्श बन गया है। फिर उन्होंने सोचा कि शिक्षा का कैसे उत्थान किया जाए, तो देखिए अब हर ज़िले में यूनिवर्सिटी खोलने का जो प्रयास है वो एक बड़ा ही अभूतपूर्व कार्य हो रहा है। कभी हमने नहीं सोचा था कि आजमगढ़ में विश्वविद्यालय हो जाएगा, गोरखपुर में 3-3, 4-4 विश्वविद्यालय हो जाएंगे, गोरखपुर में इतने विश्वविद्यालय और हेल्थ सेक्टर में इतना अभूतपूर्व परिवर्तन होने की संभावनाएं हैं। महाराज जी, आपसे हमारा यही निवेदन है कि यहीं हम लोग एक हेल्थ और वेलनेस सिटी बनाने जा रहे हैं, जो सुल्तानपुर रोड है, करीब 1350 एकड़ में। ज़मीन की ज़रूरत होगी तो 100 एकड़ वहाँ भी मिलेगी। और जब हम आ रहे थे तो इकोनॉमिक एडवाइज़र माननीय मुख्यमंत्री जी के वी राजू साहब ने कहा कि जाके आप आग्रह करिएगा, वहाँ जितने महान व्यक्ति लोग आए हुए हैं, डॉक्टर्स हैं, नर्सेस हैं और पैरामेडिक्स के लोग हैं, उनसे आग्रह करिए कि कैसे हम लोग दो एक तो ये विश्वविद्यालय यहाँ बनेगा। उन्होंने कहा कि बुंदेलखंड में एरिया एक बड़ी पिछड़ी हुई एरिया है, कोई वहाँ नहीं जाता है। वहाँ पे हम लोग झांसी के पास करीब 33,000 एकड़ में एक अथॉरिटी से सब ज़मीनें लेके बनाने जा रहे हैं। वहाँ भी करीब 1500 एकड़ में इसी के लिए मेडी सिटी और वेलनेस का बनाने की सरकार की योजना है। हम चाहेंगे कि आप जैसे यहाँ सेवा दे के देखिए, कॉर्पोरेट हाउसेस की हम बात नहीं करते, हॉस्पिटल की बात नहीं करते हैं, लेकिन यहाँ आने के बाद जो ऊर्जा मिलती है, जो एनर्जी चारों तरफ रेडिएट हो रही है, वो अपने आप में अभूतपूर्व है। आप सारे अभी डॉक्टर साहब से हमारी बातचीत हो रही थी तो आपने बताया शाह साहब ने कि नहीं, हमें सबसे ज़्यादा संतुष्टि यहाँ पर मिलती है, क्योंकि यहाँ पर जो देख रेख है और स्वामी जी का जो आशीर्वाद प्राप्त होता है वो अभूतपूर्व है। हम कहीं नहीं जाना चाहते हैं। तो एक जैसे चावल अगर आप पकता हो एक देख लीजिए तो पूरे चावल की स्थिति स्पष्ट हो जाती है कि क्या कैसा वातावरण होगा। तो आप लोग बहुत भाग्यशाली हैं। देखिए, हम आज पूरा आपके साथ रहने वाले थे, लेकिन आज ही $1 ट्रिलियन इकोनॉमी पे रिव्यू चीफ सेक्रेटरी साहब ने सारे विभाग के लोगों को रखा है और हम 4 एडवाइज़र का वहाँ रहना ज़रूरी है। हम बार बार टेलीफोन इसलिए देख रहे थे कि कहीं पोस्टपोन हो जाए, लेकिन ईश्वर की कृपा नहीं है कि वो पोस्टपोन नहीं हो रहा है। हम भावतोष जी से आग्रह किए हैं कि हम शाम को आके अक्सर जब आप आएंगे तो हम लोग साथ साथ मिलेंगे, स्वामी जी का आशीर्वाद लेंगे और स्वामी जी को हम लोग हमेशा दरवाज़ा खटखटाते रहेंगे कि हमारे विश्वविद्यालय का क्या हुआ, हमारे विश्वविद्यालय का क्या हुआ। और ये हम दावे के साथ कहते हैं। देखिए, आज आप सोचते होंगे कि नहीं, एक ये व्यक्ति क्या बात कर रहा है। आप देख लीजिएगा कि कम से कम 2 साल के अंदर अंदर हम लोग इस विश्वविद्यालय को बनते देखेंगे और प्रफुल्लित होते देखेंगे। ये हम इसलिए कह रहे हैं कि हमने देखा है। वो जो गोरखनाथ विश्वविद्यालय महाराज जी बनाना नहीं चाहते थे, वो चाहते थे केवल एक आयुष ही अस्पताल बनाएं। जब मेंबर ऑफ पार्लियामेंट थे तो हम ऐसे ही जाते थे, उनसे बार बार हम कहते थे कि नहीं, आप क्या एक छोटी चीज़ करें, विश्वविद्यालय बनाइए, विश्वविद्यालय बनाइए। और हम लोग बड़े भाग्यशाली हैं कि हमारे भावतोष जी जाके, जो हमारे MBBS के स्टूडेंट्स हैं, जो आयुष के हैं, फार्मेसी के हैं, इंटीग्रेटेड यूनिवर्सिटी है स्वामी जी। और हम निवेदन करेंगे अपने योगी आदित्यनाथ जी की तरफ से कि आप एक बार चलिए और आपके जब वहाँ पैर पड़ेंगे तो और हमारा वो भी विश्वविद्यालय प्रफुल्लित और अग्रसर होगा। ये हमारी आपसे आकांक्षा है। तो हम देखिए, हम क्षमा इसलिए चाहते हैं कि हम एक फिल्म जो हेल्थ साइंस की वो दिखा दी जाएगी। एक हमने प्रेजेंटेशन लाए थे, वो आप लोगों को दे दिया जाएगा। तो उसमें यह है कि 10 केवल स्लाइड है छोटी छोटी, कि भावतोष साहब आपसे निवेदन करेंगे कि वो हमारी चीज़ें आप दिखा दीजिए, जैसे जो हेल्थ सेक्टर में क्या क्या परिवर्तन हो रहा है और जो हमने बनाया है। खाली आप दिखा के थोड़ा बोल देंगे, आप गुरु हमारे हैं, तो हमारी अनुपस्थिति में, और हमें क्षमा आप लोग करिएगा, हमारी जरा सी इच्छा नहीं थी कि हम यहाँ से जाएं। लेकिन आज तो जब हम भावतोष साहब से निवेदन किया तो वो बोले कि नहीं, जहाँ आप जो कार्य कर रहे हैं वहाँ जाइए और जाके वहाँ भी अपना योगदान दीजिए। तो हमें आप लोग क्षमा करिएगा इसके लिए। और स्वामी जी आपसे विशेष हम क्षमा प्रार्थी हैं कि हम जाना नहीं चाहते थे, क्योंकि हमने, ये हमारे जीवन का सबसे सौभाग्यशाली दिन है। और अंतिम बात यही करेंगे कि आप स्वामी जी, भगवान आपको ताकत दें। हमारे दोनों जो गुरु आगे पीछे बैठे हुए हैं, माता जी जो सामने देख रही हैं, इस संस्थान को इतनी ताकत दें कि स्वामी विवेकानंद विश्वविद्यालय लखनऊ एक अपने आप में आने वाले समय में बन जाए। ये इसी आग्रह के साथ हम को जाने की अनुमति दी जाए।
Thank you, sir. Thank you for your encouraging words. Thank you, sir. Before we kickstart the CME, I'd like to express gratitude to all our speakers who are here. Now to start the first session, I would like to call upon Dr. Debashish Saha, Senior Consultant HOD for Department of Nephrology, and Dr. Javed Ahmed sir to chair the session. For the first session, I would like to invite Dr. R.K. Sharma sir, Director and HOD Nephrology and Kidney Transplant Medicine, Medanta Super Specialty Hospital. He was a former Dean Director of SGPGIMS Lucknow and HOD of the Nephrology. He has authored many books and has multiple national and international publications to his credit. He is a stalwart in the field of nephrology, has multiple oration awards, most prestigious being the Vigyan Gaurav Award. Dr. Sharma sir.
सर फाइल नेम नहीं, फाइल का नाम क्या है?
Respected Swamiji and Professor Viswas and other senior dignitaries and consultants and friends. I think you can hear me. Okay, I'll speak louder. Today I'm going to talk about the cardiorenal metabolism syndrome, how the heart and kidneys they are linked together, because the next presentation is by Dr. Nakul Sinha, who is a very senior cardiologist. So I'm going to present what are the disease modifying drugs which are coming up, trying to intervene on this cardiorenal metabolic axis, because these are very closely linked together. And one of the drug which we know is finerenone, which has been approved for use in India in diabetic patients who have kidney involvement, chronic kidney disease, or with initial microalbuminuria. It also has been shown to slow down the reduction and decline of kidney function, as estimated by EGFR, development of end-stage kidney failure, cardiovascular death related to heart, also myocardial infarction and hospitalization because of heart failure. So this is a drug which is actually a disease-modifying drug, both for kidney disease and also for cardiac manifestations. This is a typical 60-plus old person who has involvement of the heart. He has been diabetic and has also chronic kidney disease. He has a heart failure which has normal ejection fraction. So this is another cardiac manifestation. When you do an echo, you find that the ejection fraction is normal, but he has heart failure, which as confirmed by the anti-proBNP biomarker being increased, and plus he is symptomatic. These are difficult to treat patients with heart failure with normal ejection fraction, who also have associated renal kidney involvement because of diabetes. His GFR, glomerular filtration rate, is reduced. There is microalbuminuria, there is hypertension, and also the patient is obese. So this is a typical diabetic patients who have both cardiac and renal involvement. The common risk factors which we find in this metabolic syndrome, which is becoming very common because of the lifestyle which we are living, is the age. The older individuals have more of this syndrome, high blood pressure, increased lipids, diabetes, obesity, and the lifestyle of lack of exercise and obesity. So the factors and the pathways which we know, especially the sympathetic neurohormonal activation, the inflammation, endothelial dysfunction, and fibrosis, along with oxidative stress. So these are the pathways which start playing and get activated in this cardiorenal metabolic syndrome. And these patients have both cardiac and renal disease, like a chronic heart failure, which may or may not have reduced ejection fraction, and the kidney disease as picked up by the proteinuria. The earliest manifestation of diabetic kidney disease is by microalbuminuria. The kidney function may be normal, even the GFR may be in the normal range, but they will have microalbuminuria, which is the earliest manifestation. So these three important drugs, which we call as the three pillars of intervention in this cardiometabolic syndrome, is the blocking the renin-angiotensin system by either ACE inhibition or by receptor blockers, using the non-steroidal MRAs, which is Finerenone I mentioned, and the other is the SGLT2 inhibitors like DEPA or AMPA groups of drugs, which are also anti-diabetic. So I think this is essentially showing that patients who have chronic kidney disease, cardiac involvement, who also may have heart failure, they are the ones who have, in combination, if they present, the highest morbidity and mortality. And as you can see here, the risk of cardiovascular disease actually increases tenfold when you have this combination of this cardiometabolic syndrome. So what we need is we need to have a multi-pronged approach in tackling these patients with cardiorenal metabolic syndrome. And in that approach, as I mentioned, the albuminuria or microalbuminuria, where you may find that the urine routine examination, the protein may be abnormal, but if you look for microalbuminuria, then these patients will be picked up very early. The idea is that the renal problems should be picked up and intervened at the earliest, along with the cardiac manifestations. And by intervening by these three pillars, as I mentioned, the ACE inhibition or receptor blocker, using SGLT2 inhibitors, and using the Finerenone, which is a MRA, is really a very effective approach in tackling both the cardiac aspect and the renal aspect of this syndrome. So this is recommended in the patients who are diabetic and who are found to have microalbuminuria at the early, but later on you may find that the proteinuria may become much more quantitatively, and then you may find that the glomerular filtration rate, the GFR, also starts coming down. So there is data in a way that albuminuria, as picked up by a simple urine examination, especially the microalbuminuria, is linked with the heart failure and also with the progression in the heart failure. So if you pick up these patients early by just microalbuminuria and start intervening, you will not only retard and control the development of and progression of kidney disease, but also you would be picking up patients with cardiac disease and also with patients with heart failure. So this should be our approach. This is a very simple test. You only need to do a urine examination and serum creatinine from a standard lab, which is easily available. So, and pick up these patients at an early stage. The data has shown that if you intervene by these three drugs which I mentioned, the ACE inhibition or receptor blockers, or the SGLT2 inhibitors or Fineron, and bring down the albuminuria, you are not only taking care of the kidney, the renal risk, but also reducing the cardiovascular complications, including heart failure. So I think as a physician, we have to be aware that by these interventions, which should be done in all patients who are eligible at an early stage and effectively. The idea is that a very simple biomarker like urine protein or urine microalbuminuria is our target when we pick up these patients early and use these interventions, the three pillars which I mentioned, to produce remission. The idea is that the microalbuminuria disappears by our intervention. So that gives an idea that these patients are going to remission and our therapy and interventions are going to be effective. So Fineron, which blocks the mineralocorticoid receptor overactivation, that's how it works. It's a drug which is very effective and should be used in all the eligible patients who have diabetic proteinuria as the earliest manifestation and also the cardiac involvement. I will not go into the detail, but the other aldosterone antagonist like spironolactone is also effective, but the side effects are much more. And these drugs have to be used over a long period of time. So Fineron is not only effective as a blocker of MRA, but it is also usable much more easily over a long period of time. And its side effects are much less. Like spironolactone have more side effects of hyperkalemia, has also the sexual side effects, and also it has more CNS penetration. So these side effects you don't see with the use of Fineron. That's why Fineron is a good alternative, and it is also having special anti-inflammatory and anti-fibrotic properties. So that is taking care of the not only renal fibrosis but also cardiac fibrosis, and trying to control, prevent or retard both the renal and the cardiac manifestation of this renal metabolic syndrome. I will not go into these trials because we have had very effective phase 3 trials which have shown that Fineron is effective and shows and slows down the progression of chronic kidney disease and is also producing remission of proteinuria. So this is one drug besides the SGLT2 inhibitors, which we know, which have been approved and for use in patients who are diabetic and have chronic kidney disease in the form of earliest being microalbuminuria and also may have cardiac manifestations. These are the earlier studies where ultimately the phase 3 program went into using Fineron in patients with chronic kidney disease. This is just to mention the Figaro, Fidelio, and a combination of the data of these two studies, the Fidelity study, which went a long way to show that use of Fineron in a large number of patients, more than 13,000, in a randomized way, effectively slows down the progression and also can produce remission of diabetic kidney disease. These studies have shown that we should pick up these patients early, even before these patients are symptomatic. And as I mentioned, the two simple tests of serum creatinine and urinary microalbumin, which can be done in a good lab, can pick up very early involvement of diabetic kidney disease. So you pick up these patients and then start treating them with ACE inhibitors or receptor blockers, plus using SGLT2 inhibitors and also combining the use of Fineron. The ultimate goal is that either you are able to produce total remission, which means that the proteinuria will disappear. But even if that is not achieved, because sometimes these patients present late, you may be able to reduce the degree of proteinuria. Like proteinuria may be 2 grams. When you intervene with these 3 interventions, the proteinuria can come down to less than 1 gram or even up to 500 milligram. And ideally, we want to look at our target of total remission of the microalbuminuria. The Fineron has also been shown, besides SGLT2 inhibitors, both the cardiac and the renal outcomes in patients with diabetic chronic kidney disease. So it has been shown effectively to also in a way control the progression of diabetic kidney disease and also the diabetic heart failure. As I mentioned, this is one of the biomarkers which has been was really tested in this big study where patients were up to 13,000, where the anti-proBNP, which was a marker of cardiac failure, even with preserved ejection fraction, it came down after using these interventions in these patients. And what was shown that the composite cardiac and the renal endpoints, they were very well addressed in these studies, which were basically in terms of the cardiac failure, the heart failure, and also the reduction in the eGFR and the albuminuria. And these were done even in terms of the hospitalization because of heart failure. So it is addressing the heart failure related hospitalization also. And also it was irrespective of whether it was an atherosclerotic vascular disease, because people are worried that those diseases may be very difficult to address, but it has shown that even these patients, whether they had atherosclerotic or it was a non-atherosclerotic, the intervention with Fineron reduced the cardiovascular risk effectively in these big studies. And that's why both the composite cardiac and the renal endpoint, there was significant risk reduction as a result of these interventions. So what we have a setting where these 3 pillars of intervention, the SGLT2 inhibitors, the ACE inhibition or receptor blockers and finerenone are effectively taking care of reducing the incidence of all-cause cardiovascular mortality, besides the slowing down the development or progression of the renal disease. So I think what we need to understand that the side effects of this drug should be looked for, like finerenone can produce hyperkalemia. If the hyperkalemia is there, you have to look at it. The question of acute deterioration of the renal function, which has been demonstrated both with finerenone and also with SGLT2 inhibitors and also with ACE inhibitors. There may be, initially when you use these drugs, the eGFR may show a dip, but it is not very significant. It doesn't result in a severe acute kidney injury, and it is manageable. The other side effects are really not different than the placebo group. So I think hyperkalemia, we know that how to manage. So if they develop hyperkalemia, you use anti-hyperkalemic measures in these patients. These are some of the studies which are going on, especially in patients with kidney disease and heart failure, and some of them are almost finished, and some of them are in the line for being published, and they will go a long way in addressing the management of heart failure. Now we have a standard protocol for heart failure management, but there are subgroups of heart failure patients who are difficult to manage. As I mentioned, patients with preserved ejection fraction who have heart failure, they are not very easy to handle with the present heart failure intervention protocol. So those are the patients which are also being addressed in these studies. So ultimately, to end, the three pillars which I've shown are the use of ACE inhibitors, receptor blockers, SGLT2 inhibitors, and finerenone. So we should, as soon as these patients come to us, we should start our interventions. And the idea is, as I mentioned, the addressing the degree of proteinuria. Start very early when the patients have microalbuminuria. And the idea is to either produce total remission, disappearance of microalbuminuria, or reduction in the proteinuria. So these are the three pillars which will not only address the chronic kidney disease development in diabetics, but will also take care of the heart failure and the cardiac manifestation. I would end here, and if there are any questions, I can take or any input. Thank you very much.
Sir, thank you, sir, for your nice talk. As a physician perspective, we are admitting sick patients in our wards, in ICU. Patient comes with sepsis, and they have both the things, like